Start.
হ্যাঁ, দেখতে পাচ্ছি স্যার, পাচ্ছি।
Please start, Mosumi. You are live. Mosumi, please start.
Will I start?
Please.
Okay. Thank you. Thank you, sir. Good evening, everyone. Welcome to the online platform here. Today, here we gathered for the captivating 18th online lecture series, thoughtfully curated by the Education Committee of Physiological Society of India. Physiological Society of India is a very oldest, renowned, and prestigious organization of the physiologists. It is mainly Kolkata-based organization, and I am very much honored to be a part of this organization. This organization is doing a wonderful and commendable job in case of research and lecture, and also the objective of this organization is to spread the knowledge of various systems of physiological system. PSI has launched this online series on and from July 13, 2023. From that day till today, PSI is organizing this online lecture series on fourth Saturday of every month from 7 p.m. For last few months, PSI Education Committee are organizing this lecture series on various aspects of physiology. To provide a comprehensive knowledge on various systems of human physiology, which are required very much for both graduated and undergraduate postgraduate students of physiology, and also MBBS course. So today we have the 18th online lecture series, and the theme of this lecture is the Myasthenia Gravis. Here, myself, Dr. Mousumi Dotto, Assistant Professor of Department of Physiology, Government General Degree College, Kharagpur 2, on behalf of Physiological Society of Institution of India Education Committee, would like to invite our eminent speaker, Dr. Kamalesh Dash. At present, Dr. Dash is serving as an assistant professor, Department of Physiology, Uluberia College, Howrah, West Bengal. This college is being affiliated to or by University of Calcutta. He has got his MSc and BEd from Burdwan University. He has cleared his CSIR UGC NET in 2009 and then achieved his doctoral degree from University of Kolani. He has published various research papers in various peer-reviewed journals. With this brief introduction, it is my pleasure to welcome Dr. Dash. Sir, we look forward to your insights on the today's topic entitled Myasthenia Gravis, Insight and Innovations. So welcome you, sir, and the platform is yours. Thank you.
Thank you very much, and good evening, all of you. Am I audible?
Yes, you are.
Yes. First of all, I am deeply honored to be selected as a speaker on the topic Myasthenia Gravis, Insight and Innovation. And the subtitle of the PSI online lecture series is Advancement in Diagnosis, Treatment and Management. The objectives of the today's presentation is to discuss about what is myasthenia gravis, and what is the meaning of myasthenia gravis, history of myasthenia gravis, epidemiology and types of myasthenia gravis, and myasthenia gravis and its physiology, causes, clinical presentation and impact, innovative diagnostic methods, current and emerging treatment, case studies, new innovation and research, strategies to improve quality of life suffering from myasthenia gravis, and finally, I will briefly discuss with the conclusion, that is conclude with future perspective. Now, uh, what is myasthenia gravis? Myasthenia gravis is a chronic autoimmune neuromuscular disorder characterized by weakness in the skeletal muscles, which are responsible for movement like breathing and moving parts of the body, including arms and legs. The condition occurs when body's immune system produces antibodies that block or destroy the communication between nerves and muscles at the neuromuscular junctions. This disruption leads to muscle weakness, which typically worsens with activity and improves with rest. Here, the term myasthenia gravis was coined in 1895 by neurologist Samuel Wilks, combining two Greek words as well as Latin words, that means Maya means muscles, asthenia means weakness, and gravis means grapes. So the meaning of myasthenia gravis is muscle weakness, grapes muscle weakness. Now I will briefly discuss about the epidemiology of myasthenia gravis. Myasthenia gravis is a rare autoimmune disorder with a global prevalence of 15 to 25 cases per 1 million individuals, a figure that has increased in recent decades due to improved diagnostics, longer survival, and greater awareness. Its annual incidence is approximately 5 to 20 cases per million people. Myasthenia gravis displays a bimodal age distribution, predominantly affecting women in their 20s and 30s, and men in their 50s and 60s, with younger age group, a male predominance. Geographic variations exist with higher prevalence reported in certain European and Asian countries, while less developed regions may underreport cases due to limited access to diagnostics. Racial and ethnic differences are observed as some Asian population exhibit higher rates of early onset of myasthenia gravis, and African or African American groups may present distinct clinical patterns. Risk factors include autoimmunity, often linked with other autoimmune diseases such as thyroiditis and lupus erythematosus, and the presence of thymosis in 10 to 15% of cases. Although myasthenia gravis is not inherited from parents, genetic predisposition such as special type of gene that is called HLA genes, human leukocyte antigen types, plays a major role. Pediatric myasthenia gravis is also known as juvenile myasthenia gravis, which is account for 10 to 15% of cases and manifest either as juvenile myasthenia gravis or congenital myasthenia syndrome. The congenital myasthenia syndrome resulting from genetic mutations. Advances in treatment, including immunosuppressant and biologics, have improved outcome and increased of the prevalence, especially among elderly patients. Here, this is the prevalence. Myasthenia gravis affect approximately 20 to 50% cases per million people globally, and the annual incidence is estimated at 5 to 30 new cases per million population. And already I have stated that myasthenia gravis is a bimodal age distribution, exhibit bimodal age distribution younger population, that is women aged between 20 to 40 years, are more commonly affected, and in comparison, male aged between 50 to 70 years are more commonly affected, especially those with late onset of myasthenia gravis. And in gender differentiation, early onset of myasthenia gravis, which occur before 40 years, women are more affected, uh, 2 to 3 times more common than in men. And late onset of myasthenia gravis, which is occur above 50 years, men are more frequently affected. Now, ethnic and geographic variation include that myasthenia gravis occurs worldwide with no clear ethnic uh, predilections. In some studies, East Asian population shows a higher proportion of patients with ocular myasthenia gravis, whereas generalized myasthenia gravis is more common in Western population. There are two subtypes, that is ocular myasthenia gravis is common in East Asian population, which is involve eye muscles that control the muscular contraction of the eyelids, and generalized myasthenia gravis is more common in Western countries that affect broader range of muscles. And associated conditions include approximately 10 to 15% of myasthenia gravis patient or cases are associated with thymoma, that is hyperplasia of the thymus gland or tumors in the thymus gland. Myasthenia gravis can co-occur with other autoimmune disease, that is Graves' disease, Hashimoto's thyroiditis, and rheumatoid arthritis and systemic lupus erythematosus. Now, I will briefly discuss about the types of myasthenia gravis. Myasthenia gravis is broadly classified into 8 types. The first type is OMG. OMG means ocular myasthenia gravis, and the symptoms of OMG due to are ptosis, that is drooping eyelids, and diplopia, that is double vision. These are caused due to the weakness of the eye muscles. Uh, and the second type of myasthenia gravis is onset age. Onset age, based on the onset age, they are subdivided into 2 types, E40B and L50A. E40B means early onset of myasthenia gravis before 40 years, and L50A means myasthenia gravis, that is onset of myasthenia gravis after late onset of myasthenia gravis after 50 years. Based on the antibody status, myasthenia gravis is subdivided into 3 types: anti-acetylcholine receptor antibody myasthenia gravis and anti-MARCS. What is the full form of MARCS? MARCS means muscle specific kinase. Uh, so the second subtype is anti-MARCS antibody myasthenia gravis, and the third subtype is seronegative myasthenia gravis, that is uh, due to the presence of LRP4. So, what is the full form of LRP4? Low density lipoprotein receptor protein 4. And the fourth classification is GMG. GMG means generalized myasthenia gravis, which is also subdivided into 3 types. That is bulbar muscle myasthenia gravis, involved mainly in speech, swallowing, and chewing. And the second subtype of CMG is limb muscle, that is arms, limb muscle myasthenia gravis, that is involved in arms and leg muscles. And the third subtype of generalized myasthenia gravis is respiratory muscles. There are various respiratory muscles that involved in respiration, that is diaphragm, internal intercostal, or external intercostals. This muscle is weak and causing and leading to respiratory failure. And this is the serious type of myasthenia gravis. And the fifth myasthenia gravis types is based on the associated condition, that is they are also subdivided into 2 types, that is thymoma associated myasthenia gravis and congenital myasthenia. And the seventh types is transient neonatal myasthenia gravis, or newborn babies are suffering due to transient neonatal myasthenia gravis. Mainly it comes from if the mother is affected with myasthenia gravis. And finally, the myasthenia crisis, which is occurred due to the respiratory failure. Next, I will briefly discuss about the history of the Myasthenia gravis. Uh, uh, the history of the Myasthenia gravis dates back to the late 17th century when Thomas Willis, the first, uh, described a condition resembling muscle weakness. However, the disorder was more comprehensively characterized in the 19th century by William Howrah, who identified its hallmark features of fluctuating muscle weakness. The term muscle myasthenia gravis was coined in 1895 by Samuel Wilkes, combining Greek and Latin word meaning Graves' muscle weakness. In 1934, Mary Walker discovered that the drug physostigmine, a cholinesterase inhibitor, could temporarily alleviate symptoms, establishing the role of the neuromuscular junction in myasthenia gravis. In 1895, Friedrich Jollies, German neurologist, provided the first modern description of myasthenia gravis and introduced the term myasthenia gravis pseudoparalytica. He used repetitive electrical stimulation in his studies, laying the groundwork of the electrophysiological testing. In 1901, Henrik Oppenheim identified myasthenia gravis as a distinct disorder, separating it from other neuromuscular diseases. Harvey Cushing in 1907, an American neurosurgeon, reported that myasthenia gravis cases are linked the disease to dysfunction of the thymus gland. And in 1934, as I already stated, that physostigmine is a acetylcholinesterase inhibitor first discovered by Mary Walker. Later, in the mid 20th century, researchers identified the autoimmune natures of the disease with discovery of the acetylcholine receptors antibodies in 1970 by Patrick and Lindstrom, providing definitive proof. Advances in imaging and surgery, such as use of CT scan and thymectomy, as well as development of the immunosuppressive therapies and biologics, have since revolutionized myasthenia gravis management, transforming a once life-threatening disorder into a manageable condition for many patients. In 1970, the discovery of the anti-acetylcholine receptor antibody confirmed myasthenia gravis is a autoimmune disorder. In 1980s, plasma exchange, that is called plasmapheresis and intravenous immunoglobulin, emerged as effective therapies for severe myasthenia gravis patient and myasthenic crisis. In 1990, identified a specific protein, that is called muscle specific kinase, and antibodies in the patient who were seronegative for acetylcholinesterase as acetylcholine receptor antibodies, expanding the understanding of myasthenia gravis subtypes. Immunosuppressive therapies such as corticosteroid and azathioprine become standard treatment options. In 2000, development of the monoclonal antibody therapies such as eculizumab targeting specific immune pathway. Research into genetic predisposition and other auto antibodies contributed refined understanding of myasthenia gravis. Now, I will briefly discuss about the pathophysiology of the myasthenia gravis. As I have already stated that myasthenia gravis uh, is, is, is developed due to the autoimmune dysfunction, and various types of autoantibodies are produced that targeted the acetylcholine receptors. So autoantibodies target acetylcholine receptors at the neuromuscular junction. This is the first criteria of development of the myasthenia gravis, and this lead to the impairment of the synaptic transmission between neuromuscular junctions. Here the key player of this um, um, development of the myasthenia gravis are anticholinesterase antibodies, that is 80% of the cases, and muscle specific kinase antibodies and LRP4 antibodies. Impact of the muscle function, muscle fatigue and weakness due to reduced acetylcholine receptor in the neuromuscular junctions. So the pathophysiology of the myasthenia gravis. Myasthenia gravis is an autoimmune disorder characterized by impaired communication at the neuromuscular junction leading to the fluctuating muscle weakness. The condition primarily arises from the production of the autoantibodies that target component of the postsynaptic membrane, most commonly the acetylcholine receptors. These antibodies block, alter, or destroy the receptor, preventing acetylcholine from binding and initiating muscle contraction. In some cases, autoantibodies against muscle-specific kinase or lipoprotein receptor-related protein, that is LRP4, disrupt the clustering and stability of the acetylcholine receptors at the neuromuscular junctions. This disruption reduces the efficiency of the synaptic transmission, particularly during sustained or repetitive activity, leading to the muscle fatigue and weakness. The thymus gland plays a crucial role in pathogenesis of the myasthenia gravis, with thymic abnormalities such as thymoma, thymic hyperplasia often present, contributing to abnormal T cell activation and antibody production. In rare congenital form, genetic mutations affect protein involved in neuromuscular transmission, leading to similar symptoms without an autoimmune mechanism. So the pathophysiology of myasthenia gravis highlights a complex display of the immune dysregulation, impaired synaptic function, and genetic predisposition. So in an healthy human, what happened in neuromuscular junctions? So this is the motor nerve arises from the brain, and this is the muscles, and the connection between neuron or nerve and muscle is called neuromuscular junction. The full form of NMJ is neuromuscular junction, and in the neuromuscular junctions, motor nerve or nerve ending, this is called motor end plate, and this is also called presynaptic neurons, and this is muscle cells, sarcolemma, cell membrane of the muscle cells, that is sarcolemma acts as a postsynaptic membrane. So in the presynaptic membrane, there is a vesicle known as acetylcholine vesicles, where acetylcholine is synthesized and stored via VMAT. So acetylcholine biosynthesis is a prerequisite for synaptic transmission and muscle contraction. So acetylcholine is a excitatory neurotransmitters which is synthesized in the presynaptic neuron from serine amino acid. Serine is a non-essential amino acid. To some extent, it is also known as essential amino acids. So serine is converted to the biosynthesis of acetylcholine is a two-step method where serine first converted to 2-aminoethanol by serine decarboxylase, where decarboxylation occurs, and 2-aminoethanol then converted to choline, which is mediated by an enzyme called N-adenosyl methionine or N-acetylation. Here N-acetylation occurs where methyl group is inserted into the 2-aminoethanol, and first step is choline biosynthesis. On the other hand, acetyl-CoA is synthesized from glucose, and acetyl-CoA and choline together is catalyzed by acetylcholine ester, acetylcholine transferase, and thus acetylcholine is synthesized and stored in the vesicles. When rheobasic electrical impulse arises in the presynaptic neuron, it causes depolarization, and the sodium is influxed into the intercellular space and causes depolarization. This depolarization or action potential causes opening of the voltage gated calcium channel. Thus, calcium enters into the intercellular space from extracellular space, and the concentration of the calcium is increased. Now, the SNER-mediated docking and calcium-induced exocytosis. So, docking and exocytosis causes release of acetylcholine in the synaptic cleft. Synaptic cleft is the space between presynaptic neuron and the postsynaptic neuron. In the postsynaptic neuron, there are nicotinic acetylcholine receptors, and besides there is another enzyme called acetylcholine esterase enzyme which cleave acetylcholine to choline and acetate. Choline then again re-enter or recycle into the presynaptic neuron for reuse. So When rheobasic electrical impulse arise, opening of the voltage gated calcium channel, calcium enters into the intercellular space. Calcium induced exocytosis and snare mediated docking causes release of the acetylcholine in the synaptic cleft, and acetylcholine cross the synaptic cleft and bind to the acetylcholine receptors, and membrane permeability change. Influx of sodium causes depolarization, and this depolarization causes muscle contraction, sliding of uh, actin with myosin causes muscle contraction. This whole process is called excitation contraction coupling. In case of myasthenia gravis, what happened? Some autoantibody, such as already I have stated, LRP4 antibodies, autoantibodies, acetylcholine receptor autoantibodies, and MARX autoantibodies are produced due to various reasons. I will discuss in the later what are the cause of formation of autoantibody, uh, and this enters, this binds to the uh, acetylcholine receptor in the presynaptic neurons, and prevent the synaptic transmission, uh, and this lead to weakness of the muscles, or impairment of the muscle contraction that lead to muscle weakness. So these are the pathophysiology of the myasthenia gravis. Then I will discuss about some common mechanism of antibodies elicited by acetylcholine receptor and MARX antibodies at the neuromuscular junction. So, common mechanism of antibodies elicited by acetylcholine receptors and the MARX antibodies at the neuromuscular junctions, that include the common mechanism of actions of antibody targeting the neuromuscular junctions in myasthenia gravis, focusing on acetylcholine receptors and specific protein called muscle-specific kinase antibodies. In acetylcholine receptor antibody positive myasthenia gravis, the autoantibodies bind to the acetylcholine receptor on the postsynaptic membrane, causing receptor blockage and internalization and degradation. These lead to reduction in the number of functional receptors, impairing acetylcholine binding and subsequent muscle activation. Additionally, these antibodies activate complement mediated destruction of the postsynaptic membrane, further compromising neuromuscular transmission. In MUX or MUXK or muscle specific kinase antibody positive myasthenia gravis, the autoantibodies interfere with MUX functions, disrupting the clustering and stabilization of the acetylcholine receptors at the synapse. This impairs synaptic efficiency and results in significant muscle weakness. These distinct mechanisms highlight the role of antibody-mediated disruption in the pathophysiology of myasthenia gravis, that leading to impaired neuromuscular communication and the clinical manifest of muscle weakness and fatigue. So, here, the main immunoglobulin, that is Ig1 and Ig3, which bind to the acetylcholine receptors and initiate the complement cascade system, which lead to the formation of the membrane attack system, membrane attack complex, and local disruption of the postsynaptic membrane. So, uh, first antibody from B cells bind to the uh, acetylcholine receptors, which mainly IgG. So, and initiate the complement, classical complement systems. The formation of the membrane attack complex is a critical step in the complement cascade, which contribute to the condition such as myasthenia gravis. The process begins with the activation of the complement cascade via classical lectin alternative pathway, leading to the generation of the C5 convertase. How C5 convertase is mediated, I will schematically present. First, C1q bind to the Fc region of the antibody, and this stimulate the formation of the C1R and C1s. This C1R, C1q, C1R, and C1s help to cleavage and deposition of the C4 and C2 in the postsynaptic membrane, which ultimately form C3 convertase, that is also known as C4B2A. Then C3 convertase convert C3 to C3A and C3B. C3A, C3A and C3B with the help of C3 convertase form C5 convertase, that is C4B to A3B. Then C5 convertase convert C5 to C5A and C5B, which ultimately produce bind to the C6, C7 and forming the C5-7 complex. The enzyme cleave C5 to C5A and C5B, C5B, C6 and C7 forming a cluster forming, that is C5B7 complex, which embed into the target cell membrane. C8 C8 then attach and stabilizing the molecules, and the polymerization of the C9 creates a pole-like structures and allow the recruitment of the C9 molecules. The polymerization of the C9 creates a pole-like complement activation triggered by autoantibodies, that is against acetylcholine receptors. Finally, this leading to cell lysis. In Myasthenia gravis, against acetylcholine receptor results in MAC formation on the postsynaptic membrane of the neuromuscular junctions. Neuromuscular junctions contributing to the membrane damage and impaired neuromuscular transmission. In addition, IgG1 and IG3 cross-link antigenic target leading to the internalization and degradation of the antigen in lysosomes. So acetylcholine receptor IgG1 bind to the acetylcholine receptors, which is causes internalization of the acetylcholine receptor, ultimately degrade the acetylcholine receptors. Less commonly, the antibodies are directed at the acetylcholine binding site and can directly affect acetylcholine channel functions. Besides, marks or the muscle specific kinase antibodies are different as they are mainly of the Ig4 subclass, which is movement of the binding to muscle specific kinase does not activate complement or cross-link receptors. These antibodies inhibit the binding of low density lipoprotein receptor related proteins or LRP4 to marks, resulting in impaired acetylcholine clustering. So now, in earlier slides, I discussed about the mechanism of formation of membrane attacking system and how the um, antibodies degrades the acetylcholine receptors. Now, what are the basic cause of autoantibody formation in myasthenia gravis? Number one, genetic susceptibility. Certain leukocyte antigens such as HLA, human leukocyte antigen, HLA-DR3 and HLA-B8 is they are strongly associated with myasthenia gravis, predisposing individuals to aberrant immune responses. Second cause of genetic susceptibility is the polymerization in genes related to immune regulation and tolerance, that is CTLA4 and PTPN22, that impair immune system checkpoints and leading to autoimmunity. The second most important cause of antibody formation in myasthenia gravis is defective central and peripheral tolerance. Here, two types of abnormalities occurs in the thymus gland. Number one, thymus abnormalities, and number two, peripheral tolerance mechanisms. In thymus abnormalities, in many myasthenia gravis patients, thymic hyperplasia or thymomas are present. This condition disrupts central tolerance, allowing autoreactive T cells to escape eliminations. And peripheral tolerance mechanisms such as regulatory T cell functions may also be impaired, facilitating sustained autoantibody productions. And the third cause of autoantibody formation of myasthenia gravis is molecular mimicry. There are certain environmental agents or environmental pathogens that can generate antigen which is similar to the acetylcholine receptors or muscle specific kinase or LRP4, that is low density lipoprotein 4. These immune systems response to this antigen may cross react with neuromuscular junctions components. And the number four cause of autoantibody formation in myasthenia gravis is dysregulation of the B cells and T cells. There are various types of T helper cells that are actively involved in the pathogenesis of the myasthenia gravis. Among them, Th1 and Th7 subset that promote B cell activation and antibody production against neuromuscular junctions proteins. Besides, autoreactive B cells evade tolerance mechanism, provide pathogenic autoantibodies. And the fifth cause of autoantibody formation in myasthenia gravis is thymic contribution. In myasthenia gravis, the thymus may serve as the site of autoantibody generation, especially against acetylcholine receptors. Germinal centers in the myasthenia in the thymus supports B cell proliferation and antibody productions. Thymomas, which is also known as tumors in the thymus gland or hyperplasia of the thymus gland, often expressed as acetylcholine receptors, marks and LRP4 like proteins, potentially driving the autoimmunity through epitope spreading. What is epitope spreading? Epitope spreading is one of the cause of myasthenia gravis. Initial immune response against neuromuscular junctions proteins such as acetylcholine receptors can expose additional epitopes, leading to secondary immune response against muscle-specific kinase and LRP4. There are some environmental toxins or environmental triggers that, such as viral infections, various types of drugs, such as penicillamine or other environmental factors can participate and exacerbate myasthenia gravis by stimulating autoimmune dysregulation. And finally, the complement activation is another cause of myasthenia gravis pathogenesis. And autoantibodies, particularly those targeting acetylcholine receptors, are often of the Ig1 and IgG3 subclasses. They can activate the complement system, causing damage to the postsynaptic membrane uh, and increasing antigen release and perpetuating autoimmunity. Now, what are the causes and risk factors of myasthenia gravis? Autoimmune dysfunction is one of the cause, as I have already stated that genetic predisposition and environmental triggers. And the second cause is thymic abnormalities, that is hyperplasia of the thymus gland. Thymus gland abnormalities seen up to 70% of the myasthenia gravis. Associated risk factors: family history of autoimmune disease, viral or bacterial infection, use of specific medicines such as beta blocker or quinidine. Now, clinical presentations. What are the symptoms of myasthenia gravis? Muscle fatigue is the main symptoms of myasthenia gravis, which is worsen with activity and improve with rests. Trouble in moving the neck is one of the symptoms of myasthenia gravis. And ocular symptoms include diplopia, that is double visions. Double visions, the muscle responsible for causing diplopia or double vision is the myasthenia gravis are extraocular muscles. The extraocular muscles, that is medial rectus that move the eye inwards, lateral rectus that move the eye outwards, superior rectus that move the eyes upwards, inferior rectus that move the eyes downwards, superior oblique that rotates the eye downwards and outwards, inferior oblique that rotates the eye upward and outwards. Weakness in any of these muscle can result in misalignment of the eye, leading to diplopia. And another cause of another symptoms of myasthenia gravis is ptosis. Ptosis is the weakness of the muscle controlling eyelid movement that can lead to ptosis. The muscle responsible for ptosis, that is drooping eyelids in the myasthenia gravis, is called levator palpebrae superioris. This muscle controls the elevation of the upper eyelids When it become weak due to myasthenia gravis disease, it lead to dropping eyelid. That is, and ptosis is two types. That is, in the presentation here, this ptosis is called unilateral ptosis, and if the myasthenia gravis is advanced, then bilateral ptosis may also occur. So another symptoms is called bulbous syndromes, that is dysarthria, dysphagia, and chewing difficulties. And chewing difficulty, there are various muscle involved in dysarthria. Uh, uh, Various muscle involved dysarthria. Among them, uh, uh, dysarthria means weakness in the swallowing muscles. The muscles controlling speech may become weak, leading to slurred or nasal speech. The myasthenia gravis muscle responsible for difficulty swallowing, that is called dysphagia, and difficulty speaking, that is called dysarthria, are primarily by the pharyngeal and laryngeal muscle, as well as muscle involved in articulation of the speech. And there are various types of muscle, that is pharyngeal muscles, laryngeal muscles, uh, uh, cricopharyngeal muscles, that is and vagus nerves, that is cranial nerve, 10 is also involved in dysarthria, dysphagia, and chewing difficulties. And besides, there are general weakness in the limbs and muscles, uh, is also the symptoms of myasthenia gravis. Now, the disease start with a mild ocular, unilateral ocular myasthenia gravis, and this progress to generalized myasthenia gravis and myasthenia crisis, that is respiratory failure. Now, what are the complications of myasthenia gravis? Myasthenia gravis, there are various complications. Among them, myasthenia crisis. Uh, Myasthenia crisis is one of the severe sort of uh, 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 complications in myasthenia gravis. Uh, this is a severe exacerbation of the muscle weakness that can result in respiratory muscles requiring mechanical ventilations, and myasthenic crisis may also may be triggered by infections, medication, and changes in other factors. And the second type of complication is called respiratory complications. Weakness of the respiratory muscles can lead to the difficulty in breathing, especially during myasthenic crisis or when respiratory infection occurs. This can result in pneumonia, respiratory failure, and the need for mechanical ventilations. Besides, there are other dysphagia-related complications such as difficulty in swallowing, that is called dysphagia, can lead to the aspiration pneumonia, malnutrition, dehydration, and weight loss if not properly managed. And the next type is thymoma related complications. As I have already stated that thymoma, a tumor of the thymus gland, is associated with the increased risks of myasthenia gravis, and complication related thymoma may include compression of the nearby structures such as trachea or blood vessels, and paraneoplastic syndromes. And the ocular and musculoskeletal complication is another important complications of myasthenia gravis. That is, I have already stated that ptosis and diplopia are the severe complication of the vision that is occurred due to the complication of myasthenia gravis. And musculoskeletal complications, prolonged muscle weakness, fatigue can lead to the muscle atrophy, joint stiffness, contraction, and decreased mobility if not adequately managed. And finally, the side effect of the treatment of myasthenia gravis, medication used to manage myasthenia gravis, such as corticosteroids and immunosuppressant, can cause side effects such as weight gain, osteoporosis, diabetes, hypertension, and increased susceptibility to infections. Now, what are the diagnoses? That is, innovative approaches, clinical examination, history of muscle weakness pattern, diagnostic test. Uh, this is the common test that is called hydrophonium test, or it is also known as tensilon test. Along with this rapid improvement with the symptoms, What is adrophonium test? Adrophonium test is a diagnostic procedure used to confirm the diagnosis of myasthenia gravis, a condition characterized by muscle weakness. Idofodium is a short-acting acetylcholinesterase inhibitor that temporarily increase acetylcholine level at the neuromuscular junctions, improving muscle strength in patient with myasthenia gravis. So edopodium test in edopodium test, the test is usually performed in a hospital or clinics under the supervision of healthcare professionals. The most common tests to assess muscle strength include checking ptosis, that is drooping eyelids, diplopia, that is double vision, limb strength. Indofodium chloride is injected intravenously, typically in a dose of 1 to 2 milligram. Idofodium act by inhibiting the enzyme acetylcholinesterase, which normally break down acetylcholine to acetate and choline. By blocking this enzyme, the level of acetylcholine in the neuromuscular junction increases temporarily, improving the functions of the weakened muscles. The healthcare provider closely monitors the patient for any improvement in symptoms or adverse reactions. Improvement is in muscle strength, such as reduction of the ptosis and or lifting of the drooping eyelids, or improvement of the uh, eye movement, indicates the positive result of the myasthenia gravis. Now, serological tests such as acetylcholine receptors, marks, and seronegative, that is LRP4 antibodies. Besides, electrophysiological tests such as repetitive nerve stimulation RNAs and single fiber EMG. Imaging diagnostics including neuroimaging such as CT and MRI of the thymus evaluation, and artificial intelligence based algorithms for automated analysis of the EMG pattern. Now, the treatment option includes pharmacological therapies such as rituximab. Pharmacological therapy includes anti-cholinesterase agents such as pyridostigmine, improve the neuromuscular transmission. Immunosuppressive therapy such as corticosteroids, azithromycin, mycophenolates, monoclonal antibodies such as rituximab and eculizumab for refractory myasthenia gravis. Surgical intervention, thymectomy, and effective in patient with thymoma. Supportive therapy includes plasmapheresis and intravenous immunoglobulin during crisis. Now, what are the innovations in myasthenia gravis treatment? Emerging therapy includes complement inhibitors such as ravulizumab, FcRn inhibitor, that is rojanolixizumab, reduces pathogenic antibodies. Gene therapy and stem cell research, and this is potential for future cures. Telemedicine integration is important for remote patient monitoring for symptoms and management. Recent research and innovation in the treatment of myasthenia gravis include complement pathway inhibitors epgartimod, uh, such as epgartimods and glucoplan. B cell targeted therapies include rituximab and inebilizumab. Rituximab is a CD20 monoclonal antibodies that deplete B cells, which produces pathogenic autoantibodies. Recent studies highlight its efficacy in marks antibody positive myasthenia gravis as a potential option for refractory cases. In ebijumab is another monoclonal antibody that target the CD19 on B cells and plasmoblast, showing the potential benefit in decreasing disease activities. Besides, there are some other monoclonal antibody that act on HCRN blockage that include two types of monoclonal antibody, that is rojanolixizumab and epgartimod. These two drugs mainly enhancing the clearance of the autoantibodies. These are undergoing trials and becoming a pivotal part in the myasthenia gravis management. Uh, uh, Moreover, RNA-based therapies such as research is exploring RNA interference, that is RNA AI technique, to inhibit complement proteins, particularly complement C5, as an alternate to traditional biologics. Finally, the broader immunoglobulin, new approaches including cytokines inhibitors and advanced immune modulator are being developed to reduce systemic immune response while preventing overall immune functions. There are certain monoclonal antibodies based on therapies for myasthenia gravis patient, such as uh, some monoclonal antibody act on cluster difference factor, that is CD20, CD38, and CD40. Uh, it includes rituximab, and the company is Gentech. And the treatment protocol vary from 375 milligram intravenous weekly for 4 weeks, and repeat dosing of 6 mO single IV infusion for 500 gram. Rituximab is a CD20, and the company is Gentech, which is under phase 2 studies. Phase 2 studies. So TAC 79079, which is also phase 2 trial, started CD38, and the company is TECDA. Phase 1 study used IV and SC. Subcutaneous and intravenously it is used for administration. And iscalimab, that is CD40, the target site is CD40. There are certain monoclonal antibodies that act on FC region, FcRn region of the antibodies, that include efgartigimod, rojanolixizumab, nipocalimab, and batoclimab. These are acts on FC region of the antibodies. These are the standard administration and the target sites. But eculizumab FDA has approved for treatment for myasthenia gravis, which is a complement inhibitor 5. Uh, so there are the target site and the monoclonal antibodies based therapies for myasthenia gravis, that is iscalimab mainly act on CD40, and rituximab, uh, ofatumumab, or obinutuzumab, this act on CD20. TAC 079 acts on CD38, and belizumab acts on BAFF, and eculizumab mainly inhibit the complement pathway system, or complement pathway, classical pathway. On the other hand, rojanolixizumab, efgartigimod, and batoclimab mainly act by inhibiting the FcRn region of the uh, antibody. Various uh, plant extract with potential benefit for myasthenia gravis. Myasthenia gravis is an autoimmune neuromuscular disorder, as I have already stated, caused by body's immune system attacking the acetylcholine receptors at the neuromuscular junctions that lead to muscle weakness. But recent plant-based treatment for myasthenia gravis aim to improve symptoms by modulating the immune systems, enhancing neurotransmission, or reducing oxidative stress. While research is going on, some plant shows promising in supporting myasthenia gravis management. Among them, uh, Withinia somnifera, which is commonly known as ashwagandha, and the key benefit of the use of ashwagandha is to enhance. It enhances the muscle strength and endurance, modulate immune system, reduces the autoimmune activity, reduces stress and fatigue, common issues in myasthenia gravis. And the active compound is withanolides. There are two forms of withanolides A and withanolide D. And what are the common mechanism of withanolides A and D? This active component may improve neuromuscular transmission by reducing oxidative stress and inflammation, and support overall energy metabolism and improving resilience in myasthenia gravis patient. So this is the proposed molecular mechanism uh, that that plays an important role in myasthenia gravis. So these withanolides A and D may improve neuromuscular transmission by reducing oxidative stress and inflammations. And the second uh, plant extract, that is curcuma longa, that is known as turmeric, is also shown some beneficial effects on Myasthenia gravis. And this plant extract contain curcumin, a potent anti-inflammatory and antioxidant compound, reduce autoimmune activity by suppressing anti-inflammatory pathways, and protect neuromuscular junctions from oxidative stress. And the active compound of curcumin, turmeric, is curcumin with additional bioactive polyphenols. And the mechanism of action includes inhibit nuclear factor kappa that B, that is NF-kB, and pro-inflammatory cytokines which are involved in autoimmune response. And besides, it also enhances mitochondrial functions and reduces oxidative stress. So curcumin inhibit pro-inflammatory functions and prevent the formation of uh, mm, membrane attack complex by inhibiting C5b9. Besides, this plant extract have also showed some potential benefits. So we have to do some further research, and we have to generate some nano-based medicine based on these studies. Such the plant includes ginseng or a panax ginseng, which improve overall energy levels and modulates the immune functions, may help restore neuromuscular functions. Active compound is gelsonides. And licorice is another important plant that exhibit anti-inflammatory and immunomodulatory effect, may help regulate immune response to myasthenia gravis. And active compounds is glycyrrhizin. And Brahmi is also known as Brahmi vegetables, which is known for neuroprotective properties, may support acetylcholine productions and improve cognitive and muscular functions. Then drumstick for Moringa oleifera, rich in antioxidant, anti-inflammatory compounds, may reduce oxidative stress, which is linked to autoimmune disorders. And finally, Camellia sinensis, which also known as green tea, contains some EGCG, an antioxidant with immunomodulating properties. So, then I will briefly discuss some case studies. A patient profile, a 45 years old female uh, uh, with ocular symptoms progressing to generalized weakness, diagnosis positive acetylcholine receptor antibodies, RNA shows decremental response, treatment plan pyridostigmine, which is a acetylcholine esterase inhibitors, some steroids, and thymectomy. And outcome significant improvement after thymectomy and immunotherapy. Key lesson learned from this study: it is learned that early diagnosis and tailored therapy are crucial for better results. And the case study two, uh, mm, uh, a young female with ocular myasthenia gravis, and the age of the woman is 28 years, and the symptoms intermittent drooping of her left eyelid, that is ptosis, and deep pupil, that is double visions. Clinical examination shows that unilateral ptosis and weak ocular muscles that lead to the ocular double visions. Diagnostic test, serological test, positive anti-choline receptors antibody, anti-marks, and LRP4 receptors antibodies have been found. And electromyography, repetitive nerve stimulation, uh, showed a decremental response. And besides, imaging CT scan of the chest revealed that no thymoma. Management and outcome: the patient was started with pyridostigmine and acetylcholinesterase inhibitors and low doses cortical, and her symptoms improved significantly with 2 weeks. And finally, severe generalized myasthenia gravis with respiratory crisis. A 55 years old male patient presented to emergency department with progressive muscle weakness and problem in the respiratory issues, difficulty in swallowing and shortness of breathing over last 3 days. Symptoms: generalized fatigue and double vision for 6 months. Clinical examination: bilateral ptosis, nasal speech, neck flexor weakness, and difficulty lifting his arm, reduced force vital capacity. What are the diagnostic tests? As I have already stated, serological is positive anti-acetylcholine receptor antibodies, EMG repetitive nerve stimulation revealed a decremental response. CT scan of the chest showed enlarged thymus gland consistent with thymoma. Management: plasmapheresis, intravenous immunoglobulin, pyridostigmine, and some immunosuppressive corticosteroid, thymectomy, and immunosuppressants. Over 6 months, the patient muscle strength improved significantly and he returned to his daily activities with minor limitations. Now, I will briefly and very quickly discuss about the effective strategies to improve the quality of life of myasthenia gravis. Number one, I have already stated that medicinal management, medication adherence, consistently taking prescribed medication such as acetylcholinesterase inhibitors, corticosteroid, and immunosuppressant. Along with this, crisis management in case of respiratory failure or respiratory problem, ensure access treatment like plasmapheresis or intravenous immunoglobulin during myasthenia crisis. Thymectomy surgery may benefit those with thymoma or generalized myasthenia gravis. Number two, physical activity and rehabilitations. Tailored exercise program, that is low impact exercise like yoga, pranayam, exercise, walking to maintain muscle strength and endurance without causing fatigue. Muscle therapy helps to improve mobility and manage muscle weakness. And the lifestyle changes is another important strategies to improve quality of life. Energy conservation, uh, scheduling activities during peak energy times and taking frequent break to avoid fatigue. Healthy diet is essential for improvement of the quality of life suffering from myasthenia gravis, such as low food map diet and Mediterranean diet is recommended, along with diet rich with fruits and vegetables, lean protein, and whole grain to support overall health. Adequate sleep is important because it prioritizing rest to allow the muscle recovery and minimizing fatigue. And number four, emotional and psychological support, because myasthenia gravis is suffering from many years or so the patient become depressed. So counseling and support group is essential for myasthenia gravis patient. So joining a myasthenia group support, that support to share the experience, that reduces the feeling of isolation. Stress management, practicing mindfulness, meditation, relaxing techniques such as relaxing music to lower stress, which can worsen the symptoms. Preventive measures, avoiding triggers such as identifying and avoiding factors like extreme heat, infection, overexertion that exacerbate symptoms, and regular vaccine, that staying updated on vaccination to reduce the risks of infections that can trigger myasthenia crisis. Assistive device for modification, there are some limitation due to myasthenia gravis or muscle weakness. So adaptive equipment such as using various types of tools like grab bars, walker, and voice amplifier to assist with daily tasks. Workplace accommodation such as implementing flexible work hours, reduce physical demand, and remote work options. And regular monitoring and follow-up is important to improve quality of life of myasthenia gravis. Routine checkup with neurologists to monitor disease progression and adjust treatment plan. Early detection and management of complications like respiratory issues or medication side effect. Finally, education and awareness of the family members, others family member is extremely important, because educating the patients and family members about myasthenia gravis, its triggers and management strategy, promoting self-advocacy to seek timely medical care and necessary accommodations. So now I very quickly discuss the summary and key takeaways. So as I have already stated that myasthenia gravis is an autoimmune disorder with significant impact. Early diagnosis using innovative tools improve outcomes. Advances in treatment like monoclonal antibodies and complement inhibitors offers hope. Future research aim for personalized therapies and improve quality of life. And key point to be remembered that myasthenia gravis is autoimmune disorders that block acetylcholine receptors. And the symptoms include muscle weakness, ptosis, that is weakness of the upper eyelid, diplopia, that is double vision, dysphagia, dysarthria, fatigue, overall fatigue. Diagnostic test, hydrophodium test, antibody test, and EMG, and along with CT scan and MRI. Treatment protocol, acetylcholinesterase inhibitor, immunosuppressive therapy, and thymectomy. Management, early diagnosis and treatment are key to managing symptoms and improving. So, uh, mm, so these are the reference of my presentations. Myasthenia gravis is a worldwide or global occurrence. So the global awareness is very much important. So the quote should be, from weakness to wellness, fighting myasthenia gravis with determination, and break the fatigue and build the future. Treat myasthenia gravis with care. So finally, I am deeply honored to be selected as a speaker on the topic Myasthenia Gravis, Insight and Innovation. I extend my heartfelt gratitude to the organizing committee, Education Committee, Physiology Society of India, President of Education Committee, for this incredible opportunity to share knowledge and insight on this critical subject. The platform allows me to contribute to raising awareness, exploring innovations, and fostering discussion that could make a meaningful impact on the understanding and managing myasthenia gravis. Thank you for your trust. It is a truly a privilege to engage with such a distinguished audience. Thank you, sir. Thank you, everybody. So I finally thank you all the members of the education committee with a quote from Hippocrates, who is the father of medicine, and that our food should be our medicine, and our medicine should be our food. And finally, last quote of Hippocrates, father of medicine, is that walking is the best medicine for human health. Thank you all.
Thank
It's
you,
now
sir. Thank you, sir, for your nice presentation and such a nice way you presented in your all slide and also the future perspective of research. So now I am going to invite Dr. Kaushik Bharati, the Vice President of Physiological Society of India and the advisor of the Physiological Society of India Education Committee, in the question and answer session. Sir, you are in the platform now. So, Dr. Das, we have lots of questions from the audience. Okay, so I
Yes,
will
yes,
show you the question one by one. So, if you wish, you can answer, or you can, if we have very short of time, then the student or the participant can directly email you or contact you in
yes,
future.
yes.
Okay. Okay. So this is the first question raised by Shomendu Sarkar from Serampur College. Sir,
Yes.
is there
Uh,
any effect of thymic hyperplasia on myasthenia gravis?
Yes, yes. As I have already stated that thymus gland it plays an important role for production of the autoantibodies, and thymomas, that is, as I have already stated, that hyperplasia of the thymus gland or tumor in the thymus gland may cause for production of the autoantibodies that include uh, 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 acetylcholine receptor antibodies, or muscle specific antibodies, or low density lipoprotein receptor antibodies. So thymic hyperplasia may affect uh, in the pathogenesis in the pathogenesis of the myasthenia gravis.
Thank you, sir. Uh, Another question raised by Rohan Datta. So he's also from Serampur College, same one. And what about the alternative treatments and special diet?
So
I think,
as I
yeah.
have yes, yes, yes.
Yes, you
This is
already
a very
discussed about it.
Yes, this is a very good question. Actually, Mediterranean diet and low food map diet is recommended and the diet which is rich in fruit, vegetables, and some plant-based or herb-based medicines, uh, uh, such as Withinia somnifera, that is ashwagandha or cucurmine. So we can take it in daily basis. But proper consultation should be taken, because some patient cucurmine or withanolides extract of ashwagandha may be not appropriate. So proper consultation should require.
Okay, thank you, sir. Another question from Ishita Nayak. She is also from Serampur College. And how balanced diet impacted on myasthenia gravis?
There are certain foods that causes inflammations, some allergens, or some as I have already stated, some environmental factors that trigger myasthenia gravis, that triggered the possibilities of some antigens. If the antigen or some food materials which is resembles to the structure of acetylcholine receptors, then after entering into the human body, they produce some uh, autoantibodies against marks or LRP4s or antibody against acetylcholine receptors. So balanced diet heavily impact. Besides, balanced diet also reduce some anti-inflammatory effect on myasthenia gravis. Thank you.
Thank you, sir. The next question, I do not know the name. She is from Serampur College also. So, what are the primary treatment option for chronic myasthenia gravis patient, and how do they differ from the patient having acute or severity syndrome?
So, as I have already stated in my presentation, that myasthenia gravis in early is start with some fatigueness in one eye, that is unilateral ptosis, and then the enolatosis to progress to general myasthenia gravis, and then respiratory failure or respiratory crisis. So early diagnosis is extremely essential, and the cause of the myasthenia gravis is thymomas. Thymomas means hyperplasia of the thymus or tumors in the uh, thymus gland. So, what are the primary treatment options? So, the primary treatment option, use of anticholine, anti anti-acetylcholine esterase, that is pyridostigmine, is the anticholine esterase inhibitors, and along with this, some immunosuppressants, some corticosteroids, and may be used for the treatment of uh, myasthenia gravis.
Thank you, sir. Last question from Rimita Pal. Why the diagnosis of myasthenia gravis often delayed, and what are the diagnostic tests are typically employed to confirm the condition?
Yes, the confirm test, as I have already stated, that hydrophonium test is the confirm test. But hydrophonium test nowadays, some CT scan or MRI or serological tests such as acetylcholine receptors antibodies or marks, or marks antibody, or LRP4 receptors confirm that the patient is suffering from myasthenia gravis. There is a CT scan or EI based analysis of EMG. These are the modern technique used in identification of myasthenia gravis.
Thank you, sir. Thank you again for your such a nice presentation, as well as to deal the question answer session from the different student. So now I am handing over the session to Dr. Kaushik Bharati sir for the vote of thanks. Sir, please.
Thank you very much, Dr. Arnab Banerjee. Uh, First of all, I must thank our enlightened speaker, uh, Dr. Kamalesh Das, for an excellent lecture. He had such a grasp of the various topics, most notably the immunology part, which is a very difficult topic, but he handled it very nicely. And he touched upon all the aspects of Myasthenia gravis. Some observations I want to make. Learning experience. Most of us know that Harvey Cushing is responsible for first describing Cushing syndrome, but little do we know about his contribution to Myasthenia gravis. So this is a new aspect that we learned from Dr. Das. And he talked a bit about the ptosis, that is drooping eyelids. This is a classical symptom that you see in case of neurotoxic snake bites also, and snakes like cobra, coyote, and also others also like kalach. This is a Indian common crate, as well as the shakamuti or bandit crate. These you see in these cases. And what I would have liked to mention is that an anecdote that our famous actor Amitabh Bachchan is a classic case of Myasthenia gravis. So, this is not many people know about this. And another thing, I have some reservations for the monoclonal antibodies because this is very expensive actually, and making them is very difficult. I was involved in developing some monoclonal antibodies during my time at the National Institute of Immunology. So fusing these myeloma cells with the lymphocytes is very difficult. You have to use polyethylene glycol, and it usually becomes destabilized. So it's very difficult, and the cost is very high. It can be as high as 45,000 for a treatment course. And we observed this in the COVID-19 pandemic, where IL-6 inhibitors were being used, monoclonal antibodies, and which was mostly out of the reach of people in places like India. So, with these few observations, of course, I thank Dr. Kamalesh Das. I especially I want to thank our respected president, Professor Prasun Priya Nayak, for his constant support for the PSI Education Committee in many ways. And I would also like to thank uh, Dr. Shampa Sarkar Biswas for her constant support in taking care of the platform and for hosting the event. I would also like to thank uh, Dr. Arnab Banerjee, who is here today, for taking care of the StreamYard platform and doing it so beautifully. I would also like to thank Dr. Moushami Dotto for acting as the coordinator, which is a very important task, and she has done it very nicely in organizing this and selecting our learned speaker, which is highly commendable. And last but not least, I must thank all of the members of the PSI Education Committee for their constant support and commitment towards the activities of this endeavor from PSI. Thank you very much. Over to Dr. Arnab Banerjee.
Thank you, sir. So we are now going to end the session and today's webinar lecture series, right?
Yes.
Thank you, sir. Thank you, all of you. Have a good night.
Thank you, sir.